And good evening. This is Bite-Sized Learning from the Ohio Academy of Family Physicians. My name is Dr. Mike Sevilla. I am your host and moderator for tonight's program. We have a great program here this evening, and we have the current president of the Ohio Academy of Family Physicians, Dr. Teresa Zryd, who is going to be joining us in a little bit. So, but first, I just want to just remind everybody, if you want to learn or want to do anything with the Ohio Academy of Family Physicians, OAFP.org is where you can find all the information. There's great CME events. You can find past episodes of this program. Anything you want to learn about family medicine, you can go to OhioAFP.org. So why don't we bring our guest on? Our guest is the current president of the Ohio Academy of Family Physicians, Dr. Teresa Zryd. So thank you for joining us here this evening. And I think you may still be on mute there.
I think someone else controls that other than me.
Very good.
Good evening, Mike. Thanks for having me.
So we're going to get right into your story in a little bit, which I'm very excited to kind of share with people. But first, Dr. Zryd, so why family medicine? Why does family medicine rock? Why is it? Why family medicine?
I think, and as you'll hear from my story going forward, is that I started out with a public health background. Actually, when I was just even in undergrad, I knew I couldn't do like a 9-to-5 job. That was not me. And so I really went in undecided and ended up happening to read a brochure about being a health educator. And I thought, wow, that sounds interesting. And it gives me a chance to kind of do a little of this and a little of that. I suspected that I might be just a little bit ADD because I didn't want to do the same thing every day. So I went through undergrad and became a health educator, and then ended up in public health later on. So when I started thinking about medicine, and again, I was a very non-traditional student, family medicine just seemed perfect. It's preventive, it's about the family, it's about the community. And I thought, well, that's stuff I already got down. And I really think from my public health days, it was really evident that if you're going to change a person's dynamics, you've got to incorporate their family. The whole family, everybody has to be included, because if it's the husband, the wife's doing the cooking. If it's a diabetic issue, the wife's doing the cooking. You got to get her involved. And family medicine, it spoke to all of those things that I could do. Plus, remember that comment about ADD. I always liked the notion of picking up back then a chart before Epic came along, before the electronic medical records came along, and going, I wonder what's behind door number 3.
Yeah, exactly.
Great foundation for medicine, in my humble opinion.
So yeah, so she did make a little bit of a reference to kind of a non-traditional, type of path to family medicine. I want you to share a little bit with us.
Sure. So when I was working on my master's, my advisor happened to be the chair of the department, and we talked about medicine a great deal. And I said, I've always kind of thought about being a physician, but I come from a military background, and no one in my family was medically directed at all. And as a military brat, so to speak, we traveled around. We tried to stay away from doctors unless we had to. Because we were always getting immunized, because we were going someplace else. So it just wasn't in the background. But as I got deeper into public health, I thought, I think I held physicians in such high esteem. And I thought this would be the best place to kind of help the individual and to help their family and to help the community. So my advisor said, well, you should go ahead and try for it. I said, no, I've spent a year and a half doing this public health stuff. I need to get out and work again. I can't stay in school. So I got out and worked some more. And as the assistant health commissioner, I had to hire physicians to help me run the clinical aspect of patient care that we had at the health department. And as I got to know them, I thought, well, if they can become physicians, I think maybe I might be able to do that too. So I told you in the story, the laughable, when I went to find out what I really needed to do to get ready to do that the pre-med advisor, looked at me and like, you're not 19 years old anymore. You don't have that retention power. And I thought, well, you don't know anything about me or what I've been doing. And I said, just tell me what I need to do. So for 3 years, I worked, and then I had to take certain classes all over again, like biology and chemistry and physics. And that took me 3 years to get that done in order to sit for the MCAT. And then I sat for, and at the end of the day, I told myself, there's a really, really good chance you're not going to get in. But I thought, in 3 years, I will be 3 years older and doing the same thing I'm doing, or I will be 3 years older and doing something that I have a passion for. So I had to at least try, so it was important that I gave it a try. And if somebody turned me down, that was fine. I tried on my own. But then they accepted me into medical school. And I'm like, oh, crap.
So it's so interesting because, these days, people coming out, they finish medical school first, and then they get their public health degree afterward. And it's so interesting how kind of did that backwards. And you maybe talked about it a little bit earlier, but what kind of drew you towards public health in the first place?
Again, it was that you had the opportunity to address more than just the person. And I really did feel a need to want to help in the healthcare area. You saw so many people. My grandmother was very poor Kentucky country woman, and her health wasn't the greatest. And I kept trying to figure out, what do we need to be doing to help these people in terms of education and information? And one of the things that struck me is that then everybody seemed to listen to what the physician had to say. So that, to me, seemed to be the place where we have the most power. That we really, if we get outside of our four walls with our background, that we can do so much good. There are those who want to take care of their patient, and I don't fault them, and that's great. But I wanted residents. That's how I ended up teaching, but I wanted physicians in general to know how much power they carried and what good they could do if someone just showed them how to do that, just to do to get some community medicine background. And it was interesting at the time, as I looked at a lot of the med school curriculums across the country and residency curriculums, there really wasn't a community medicine rotation. Not a lot of programs had it. The one I ended up in at Good Sam actually had it. And I think that was part of the draw, was that they already knew the importance of it. So that's sort of what brought me into that field, is wanting to do, take what we have and try to make it on a more grander scale and really help a lot more people.
Well, one of the things that I first learned about public health, which I didn't know was an entire area, and I'd like to talk to you a little bit about that, is the whole concept of health literacy and what that means. For people who don't know, or when you talk with medical students or residents or even attendings, what is health literacy, and why is it important for us to understand it as we're communicating with the public?
Well, I think people need to understand, it's sort of one thing connects to another, and you need to have an understanding of what's going on behind your healthcare, what's going on behind why something's happening, and what's available to you to try and address it. So just having an understanding of health literacy, and there's so many who don't really get it. They just, don't even read anything about it, or it's not discussed with them how things that they can do, change little things in their life to make a really big difference. And you're right, we physicians really didn't know much about it, nor was it really discussed much.
Yeah, exactly. When it comes to things like terminology and how we address patients, and patients who maybe live close to the hospital or live far away from the hospital, or speak a different language. I mean, all those are aspects of health literacy which I really didn't understand, but I know with your background, I mean, it's probably kind of a bedrock of what public health is, what it's all about.
You also have to take into consideration each patient's culture and what is allowable from that cultural aspect, that as you're trying to provide them with healthcare, well, you may offer something that, like, we don't do that in our culture. We have to find a way around that. So you really do need to understand where that patient is coming from and what their true needs are and how you can address it. That was one of the interesting things I think I always puzzled over, was a patient will come to you and you'll tell them this is what you need to do, and they go, well, I'm sorry, I can't do that. A, because I don't have the money to do it, because I have to buy XYZ. So my health comes last in the spectrum of things. Or two, that's just not, my family won't go along with that, so that's not going to happen. So you really do need to have that interpersonal relationship with your patient, which is again why I love family medicine. You get your one-on-one. I think a lot of them see you as their friend, that or part of the family even. I'm sure it's happened to you as much as it's happened to me. Is although you're providing the best care possible, people do die, unfortunately. But we get invited to the funerals, and they're so amazed and surprised and thankful when they actually see us there.
Exactly. So professionally, kind of what happened to you following residency, leading up to what your current job is today?
So I traveled around trying to figure out where I wanted to do medical school, and I decided that after looking at several different schools, I could get what I needed in my own backyard, so to speak. So I stayed local, stayed with Wright State, and appreciated that then they really embraced non-traditional students, which was sort of important to me too. It wasn't, I was older at the time, and I wasn't one of those people who could stay up all night studying for tests. I had to draw a line at some point in time, or I wasn't functioning the next day for the most part. So Wright State was very accepting in that, and had a lot of different non-traditional students when I was going there. Then I looked around at residency and thought, well, do I really want to be really homegrown and stay local, or do I want to see what else is out there? So again, I looked at different programs and discovered that what was in my own backyard offered the best thing too. Plus, you knew people, it was comfortable going into a place that you'd already done some work. So I think I understand medical students when they want to stay in their town where they've done medical school to do residency. I had first envisioned when I started medical school and even residency that I would become one of the family docs who went out, had a practice, saw patients 5 days a week, broke for lunch, that kind of thing. And probably about toward the end of my first year residency, I decided that, I really want to be academic physician, because my public health, my health educator background just seemed to feed right into that. I missed being able to do a lot of teaching. And although as a family doc who's in practice, you can take medical students or whatever, but it seemed like the academic route was really what was meant for me. So I went in to become faculty of the program that I graduated from. And about probably halfway through my second year, after I decided I wanted to be faculty, I decided I really would like to be a program director. It's like,
wow. Like, who thinks like that?
Well, but you have to understand, I came from being an assistant health commissioner.
Sure.
And administration was really also a sideline of mine, so to speak. Right. And as my husband used to call me, he called me a bossy pants. So it just seemed that I needed to be, somewhere in administration. So that, and fortunately, the faculty at the time and the chair of the department thought that was not a bad idea either. So so one thing led to another. And then I stayed. I loved being a program director. It is the most fulfilling, stressful, but fulfilling job there is to be in academics. And I would have been extremely happy to have remained there. However, when I was tapped to become the Vice President of Academic Affairs and Research, it was interesting, but I think more so I had a fear of, if I didn't do it, who might they get, and how might they, because they're working for the hospital, manage or think about the programs. And I really wanted to be a true advocate for both sides, from the hospital side, who's got, all the financial issues going on, to the educational side, that you're dealing with residents and you just want to get them trained, and medical students. So I wanted to be that person who understood what it was like to be in academics and try and help the financial side understand that and try and direct funds where they need to be to keep our residents moving along as we should.
Wow. I get questions a lot from medical students and residents, and you probably do too. To be in that administrative level, I mean, you do have a MPH, and does that require like a master's in business administration? Is that something that you wanted to do, or is it something like, or this specific unique job is you just learn as you go, or you have good mentors, or how was your confidence level going into this kind of academic or an administrative position?
So yeah, it's probably a little bit of all of the above. The person who was leaving the position stayed around privately to help mentor me, which was very helpful, and direct me. And I still, to this day, call her and say, all right, I've got this problem, what do you think? And in terms of, do you learn while you're on the job? Yeah. Right now I'm dealing with CMS and figuring out what residents can and can't do if we start, XYZ. So there's always something to be learned, because CMS is always changing their rules too. So it's just trying to stay up to date with those, talking with the attorneys who are very well versed in that, and then trying to make sure that we're handling everybody's interests on both sides. I like to think that from the academic side and from the hospital side, that I try to lead for a win-win on both sides, so that everybody kind of walks away feeling like they got something out of it. Because usually it has something to do with money. At the end of the day, most things boil down to money. So it's, and what value are you getting for your money? So I try to figure out where is that win-win in the situation.
It's something that I've always asked my colleagues in academics, and I'll ask you as well, and there may not even be a great answer, but how has medical education changed during this pandemic?
Let me back up a little bit further than just the pandemic. First, at least as residencies related, when we started dealing with duty hours. So we went into this, when you and I went through, there were no duty hours.
No!
We walked to school uphill both ways in the snow.
That's right. That's right.
But so that, I think, has really changed some of what we're able to do with residents and some of what they're able to do coming out. I think it was like, I remember a surgery resident telling me one time that they hated that they had to, they were doing call Q3, and they hated that they had to be off a day because they were missing those great cases. That was the driving force for us, was we're learning on these situations where we're taking care of patients. And I'm far more likely to remember something medically connecting if it's about a specific patient as opposed to something I've read. So seeing and doing far better teachers than just reading. So the duty hours have changed what our expectations of residents are. And then with the pandemic, I think I don't know that we've lost anything educationally wise. We just had to figure out a different way to do it. And I think that now trying to get residents to come back to, let's say, their didactics on a Wednesday afternoon to be all in the same room together, that may never happen again, because they're very much used to, I'm going home and I'll pull up the computer and I'm going to sit here at home and do my education that way. And it's a very big resident satisfier to be able to have that flexibility. I would say they're having this newborn flexibility that the pandemic has allowed for a lot of different positions is making a difference too in the way we do things. But I think that we will need to figure out when do we need to have people in person and when we can allow the virtual aspect.
Yeah, and it's just so interesting because I'm starting to have medical students back in my office again, and some of them are almost midway through their second year and they haven't talked to a real patient because of all the restrictions and everything of all that. And in the past, that's a lot of medical schools now really want to get students talking with patients or shadowing early in the first year, just so they can start to get used to that. So it's a whole different way of how we're doing things, and who knows how this pandemic is going to last. And it's just how much, I guess, like real life, how much has things short-term changed or long-term changed or permanently changed. And I would imagine medical education, I mean, like everything else, there's going to be some changes that are going to be permanent and some that's going to be short-term.
I would agree. And I think that at least what we've done in my system is the restrictions really came from the academic side. We made arrangements so that even medical students could continue coming and seeing patients. A lot of them were not necessarily comfortable until we figured out more about COVID, but now, then you had all those who wanted to jump in and, do whatever they could, see patients. And I think they were realizing that they were missing out on a very important aspect of their training and trying to figure out how to do that. I think that for the most part, they want to be seeing patients. And that's our job, to be figuring out how do we make that happen in a safe fashion.
Exactly right. Yeah, there's always that safety factor, which I agree is important, but it's just balancing the learning and the safety, even from a patient standpoint too. So, because I've had some patients say, "Hey, I don't want the student in because I don't know where they've been, and doc, all my medical issues," and so it's just working through that from all the angles.
It will be interesting, how we reformat all of this as we go through and figure out more about COVID and what its long-term effects are going to be, and how we have to restructure some of the medicine that we do.
I saw in your bio here that you are or are a consultant for Dayton Public Schools and a team physician for the University of Dayton, which obviously is awesome for family medicine because we have those opportunities. But can you talk a little bit about those experiences?
So the Dayton Public Schools, initially, I oversee all of their policies as it relates to their students, healthcare wise, whatever the nurses are doing in the hospitals. And then we used to do a mobile van that we would see kids who weren't able to get into a physician's office or who needed immunizations of some sort or another. The mobile vans kind of went away, so I ended up mostly now I just do I look at their policies, maybe change them a little bit, and then sign off on them so that I sign off on them being able to get flu shots, into the schools, and inhalers and those kinds of things that they can have. So I'm sort of now functioning more administratively per se than actually having any hands-on. As far as the physician, the team physician, so I did that. I'm not a super sports person. I mean, I wasn't a jock or anything coming up, but I am a UK fan, so go Cats. But
there you go.
and my son went to OSU, so I'm also a Buckeye.
There you go.
It's football for OSU and it's basketball for UK. It's just
Of course.
But I did that. I really got into sports medicine as part of the need for the residency. We needed places for the residents to rotate with sports medicine, and me being able, I volunteered my time, and then I dragged them along with me to different games. And then I was, for the longest time at Dayton, one of the only female physicians that they had. So then it was funny. Here are these family docs, and we had 4 family docs and I think 3 orthopedic docs that we rotated activities. And as soon as I came on board, all of the docs said, if a female athlete came to them, you need to go see Dr. Zryd. Wait a minute. Time out. You all were trained on both male and female. I said, wow, you guys jumped at that opportunity.
Man, that's funny.
But it's been great. I usually, most of the sports I covered women's soccer games at home, sometimes volleyball, basketball. But the guys really like covering the basketball. They weren't so hep on the soccer, but they really like covering the women's basketball. So I didn't have to do as many of those games.
So one more question about this professionally, then we'll move on to your role with the OAFP. I'm fascinated by your background in public health, and and you've already touched on it already, but I mean, are there other aspects on how your public health background and public health passion drives your work today?
I believe that, I think I stay involved in things outside of just general practice, or even in, the hospital workings or whatever. Even I think it was a push to become more active in the OAFP. I think one of the most important things we do is advocacy, both for our physicians who are trying to take care of their patients. So what we're typically advocating for is the ability to provide the best care we possibly can. And that speaks public health to me. I mean, that's what public health is about. You're taking care of your population. And, population health now has become like this big, touchstone word that everybody uses. Oh, population health is so important. I said, well, public health's been going on forever. It's the same thing. It's not as sexy as population health to say public health.
Yeah, exactly. Yeah. I mean, you couldn't even imagine, if you were a public health commissioner or assistant public health commissioner in today's world versus before. And the great, what's great about today is that we have a lot of friends and colleagues who are these public health commissioners, who are family docs, who have this passion, who sometimes have an advanced degree. And that's one of the great things of family medicine and being in that type of role.
Yes. Well, I think family medicine allows you to do so many things. You're not restricted in where your passion is. And with your family medicine background, you can go and do most anything you want. You just get a little more training in that area, and then you become the expert. All that family medicine background, plus in that added whatever it is you want to do, team physician, working in politics even. And I think that, even we've seen a lot more physicians of all specialties going into politics now. And I think that you do carry a certain bit of status with you, having been a physician previously. So, I encourage everyone to do that. Do what you can, because regardless of how it feels, that no one appreciates you, and and that you're undervalued and whatever, you have value, and you have such a loud voice when you're using it that way. And I want to encourage everyone to do that.
My guest is the president of the Ohio Academy of Family Physicians, Dr. Teresa Zryd from Dayton. And let's shift gears here a little bit. And you're the president this year. And share with me a little bit how you first heard about the OAFP and organized medicine, and how did you get first started in the academy?
Well, I first heard about the academy. Of course, the AAFP is always on everything that you're listing and what you're having to do when you go into family medicine. And the OAFP, it's like, oh wait, I'm paying dues to the OAFP.
Or somebody's paying dues.
It's like, maybe I need to figure out what these folks are doing. But I have to sincerely credit Lisa Ryder, who was one of the faculty when I was chief resident, going through the family medicine residency, who was a strong advocate in OAFP, who kind of drugged me along with her. And I'm like, oh, no. I don't need to be doing any of these meetings on weekend stuff, because I had a family, and then I realized everybody else had a family too. Couldn't use that as an excuse. So she dragged me with her, and I guess I got the bug. I thought, wow, this is great to know that there are people advocating for it. We're working out in the trenches, and there are people who carry our voice forward. And I liked that. I liked that, the notion that I might be one of those people who could carry the voice for the collective forward.
And when you talk with, even today, when you talk with students and residents and our colleagues, about the academy and why it's important. What do you tell them? Why is it important for family docs to come together in this organization? And why is OAFP should be important for family docs?
So what I tell them is that you are busy doing your everyday stuff. And I said, but there are always going to be problems that plague you in being able to do your job most effectively, like the insurance's pre-auth requirements. Lord, what a pain those were. And in terms of even our pay, having someone advocate for you to get the reimbursement for your services that you deserve, and other issues like that where you're attacked on different fronts. And I don't care what setting you find yourself in, a lot of these problems are across the board. And having a voice, somebody for you to say, look, this is a problem. Can't we do something about it? And for them to say, absolutely, we're going to take that forward and we're going to see what we can get changed. While you're still going about doing your regular job, they're doing that job for you. So I think one of the most important things, if not the most important thing for our academy, is the advocacy piece. Secondarily, they are great with education and trying to keep us. Family medicine probably has the most onerous requirements in terms of keeping credentialed and whatever. So I think they stay abreast of what we need. And they follow whatever the current trend of what needs to be taught. Like the most recent conference that you and I were just at was the limiting implicit bias, which was great. So it gives you opportunities to be educated in those things that you want to be. And you get a chance to be with your colleagues periodically, or at least virtually, to talk with your colleagues and find out you're not alone. That everybody has kind of they're frustrated and they have problems, or they're able to share something good that happened. So to me, we would sort of be like sheep out there kind of just going our own way without any direction if we didn't have the OAFP. So I'm very thankful for them to kind of keep us directed on the things we need to be directed on.
Yeah, the one thing that would want to bring out in your remarks there is we just don't want to feel like we're just alone out here, and the pandemic is still with us, and life is a lot different, and we're less in person and more virtual, and there's all this shouting that's going on social media out there, and I'm hoping that there are students and residents and family docs out there who, like you said, they just don't want to feel like they're alone just working, and that there's nobody out there who has similar values and similar problems and wants to try to come together to try to come to a solution, whether it's locally, state level, or national level. So definitely agree with all that. Let's see here. Everything else on my list here. Anything else about the OAFP before we start to kind of close up our conversation here this evening?
No, other than, I know we get a lot of folks who feel that they're not maybe getting value for their dollar, but I think those are ones who are really not looking into what the academy is actually doing for them. And I think we probably need to toot our own horn more often, and maybe a little more periodically, to let folks know what we are doing for them, and that while they may not feel like it directly affects them, it does. So I think we're doing a great job. We just need to make sure that everybody knows what we're doing.
Yeah, especially from a legislative standpoint. I read stuff all the time from AFP, and I know that, there are issues in Washington, like, the 2022, physician payment CMS thing, that was just finalized, and there were some changes that were influenced by AAFP lobbying. And those are things that people don't know about. That we're in Columbus, that we're in Washington. A lot of behind the scenes things that people don't know about until the final product comes out. But yeah, like Teresa, like you said, we're family doctors. We tend not to toot our own horn, but when it comes to things like this, I definitely agree. So as we close up here this evening, do you have any closing thoughts for our audience here this evening? Anything I didn't bring up or I didn't ask you as we close up our conversation this evening?
Not a whole lot. I think that, if I were speaking to our membership, I simply would want to tell them not to be disheartened by how things are going, because you do have people working to try and improve those. And the more we can be upbeat about what we're doing as family physicians, the more we'll attract students to come into the field. I think one of the things that I hear most often from students, and this isn't just about family medicine, but it's they look to us, they look to their rotations, they look at the docs in the community, and they see who seems to be happy and who doesn't. And while, a lot of choice, unfortunately, circles around the salary or how much money you're going to make, at the end of the day, I think folks need to be happy in whatever it is they're doing and not go into it for a money reason, but go into it because you have a passion. And if we have people out there who are very unhappy about their choice as a family doc, that doesn't help us. And the thing that we need now most of all are more of our students going into family medicine. We need everybody in this country to have a family doc. End of story. And we need to be leading that charge. We need to be figuring out what it is we're doing. If we are doing anything to turn students off, how do we turn that around?
It's well said. Yeah, we'll just leave it there. So my guest tonight has been the president of the Ohio Academy of Family Physicians, Dr. Teresa Zryd from Dayton. And you can view this or any other of our past bite-sized learning at ohioafp.org, and of course on our Facebook page and on our YouTube page. So till next time, we'll see you next time at right here at Bite-Sized Learning. So good night, everybody.
Good night.